This isn't a PowerPoint. This is actually getting into communities, getting dirty, rolling up your sleeves, working with people in communities and understanding how they live. And if you can't do that, then it's probably not the right business for you. But if you can, it's not a financial arbitrage business. It's a real care, health services, social services, whole person model. And the rewards are not just financial. The rewards of building an impactful transformational company are enormous.
Welcome to The Other 80. I'm Claudia Williams. On this podcast, we talk about how we can build health in America beyond medical care. Only 20% of overall health is determined by medical services. We are here to talk about the other 80%, housing, food, social connections, and how to move rapidly and equitably towards whole person health in this country. Integrating medical and social care is especially critical in areas like mental health, maternal health, and long-term care. We generally don't need new science or treatments, but we do need to bring care to people the way they live in their homes and communities. There are a host of startups in this space that are expanding access to mental health, making social service referrals, and using peer support and home visiting to bring care to people how and where they live. Our guest today is Andy Slavitt. He funds and partners with many of these companies through Town Hall Ventures. But you probably know him for his roles leading CMS in the Obama administration and COVID strategy in the early days of the Biden presidency. He's also the host of the award-winning podcast, In the Bubble. I'm interested in Andy's insights as a policymaker, but also his views about building companies in the Medicaid and whole person health space. So please enjoy this conversation with policymaker, investor, and podcaster, Andy Slavitt. Just a little bit of background on the podcast. It launched a couple weeks ago, and the focus is on moves to whole person health in integrating medical and social care, especially in Medicaid, but also increasingly, I think this is relevant in Medicare, especially as policymakers look at risk adjustment changes. I want to start in the Medicaid investment space because I think you're uniquely able to see both the policy drivers of that and kind of the real business issues. And I think we've known for a long time that MA, Medicare Advantage, is a huge investment opportunity, big profits to be had there. And that explains, I think, some of the difference of investment in Medicaid and Medicare, meaning mostly managed care is where the opportunities lie. But I'm increasingly feeling like Medicaid has just gotten a bad rap in the investment space. So maybe just to start with, what do you see as the real core hard challenges of both investing in and being a company in the Medicaid space? And then we'll move to the opportunities after that.
Well, first of all, I completely agree with you. It is a place that people avoid. And I think in large part, people avoid it because it just doesn't comport with the way they live their lives. So people can kind of empathize with what it's like to grow older. They can empathize with employer-based care. They can empathize with, the devices on their phone. And, many investors are, let's face it, quite well off. And so, they're looking for the next Peloton to self-actualize their life even 1% further. But that doesn't mean that those are the most important priorities for the country. Investors either tend to think of things one of two ways. The traditional way is, where can I make money? And so, okay, MA sounds like a rich pot of places to make money, and that doesn't always mean that you're creating companies that are adding real value. The other way is to look at it and say, what are the big challenges that need to be solved, and can we solve these challenges in a better and a more creative way than that are currently being solved because we know these people, these populations better. And the way we look at the world is we don't have one healthcare system in this country. We kind of have two. If you're employed with a salary, you get employer benefits, you've got reasonable savings. That describes about half the country. In that situation, you have access to preventative care. You have access to primary care. You have access to specialty care. Your chronic disease burden is relatively low. You live to be in about the mid 80s on average. But the other healthcare system, the one that you're in if you work an hourly job, if you are a single parent, if you are older and you've spent through your assets, if you have a disability. Describes about 130 million people in this country. It's not small. You have no access, generally speaking, to primary care, even less access to specialty care, a chronic disease burden that's 2 to 3 times higher than the first group. And you live about 8 to 10 years less. It's the sad reality in the same country. And the most interesting insight, Claudia, to me is that people in the first group and people in the second group have the exact same medical conditions. Diabetes is diabetes. High blood pressure is high blood pressure. Kidney disease is kidney disease. It's not a function of do we need new science to do better in order to shorten that 8 to 10 year gap in life expectancy. We don't need new science. We actually just need to bring care to people the way they live. So it's about equity and access. It's about something far simpler. It's about saying when we're waiting for you to get sick and use the emergency room, we could be investing in prenatal care. We could be investing in mental health care, pediatric care, all these kinds of things that make an enormous difference because we're going from zero to something. We're not going for that 1% more self-actualized experience. We're going from zero to something and something good. And so working with companies who say, I have an idea for a physical, behavioral, social model that wraps around people's lives, around a specific need that they have. And I know this community well because I've lived in this community. And I know these people well. I have an idea to make this better. That's the stuff I get excited about. And, not all those things have potential to do what they think, but increasingly, because you have Medicaid managed care, because you have duals, because you have C-SNPs, because you have CMMI and a lot of the models that they offer, there are increasingly ways to say, yes, if I go invest in these communities and help get people a better answer, I can make a margin, not necessarily a huge margin, but I don't think you got to make a huge margin in healthcare. There's a lot of people to be helped.
That is incredibly compelling, and I agree completely. And I think part of what you're saying is we need meaningful companies that don't want to make the top buck, but that are making a huge impact in the world. Let's imagine I am a potential founder and I'm convinced by that, but then I go talk to other founders in the space. They say, yeah, but churn is really hard. Selling state by state is really hard. Being able to scale in the absence of a policy mechanism that kind of acts once and goes across all the states is hard. So let's unpack that a little bit, because I think those are real pragmatic challenges. What are some of the ones that you think are most important, and are there ways to kind of address them?
I think people who haven't worked with government before tend to shy away and tend to feel like, oh, maybe it's not a good thing to do. And the reality is, if you're in healthcare, whether you know it or not, in some form, you're a government contractor. So as for 50 states, let's start with that. If I told you you were an employer-based business and there were only 50 employers in the country to sell, you'd think, oh, that doesn't sound hard. And you'd probably say, some are good, some are bad, some we'll be aligned with, some we won't. Some have budgets, some don't. Some have good people, some don't. That's exactly how it is. States are just, stop thinking about them as government and start thinking about them as customers. Start thinking about them as people who have needs, varying degrees of resources, varying degrees of expertise, and need for a solution. And yes, I think for people who haven't been involved in government before, it feels like, oh, there's all these external factors like a legislature and a governor and all that. And that has kept people away. But those are kind of moats in many ways for people who understand it and want to go at it. And I would never tell anybody that you should go if you're working in Medicaid in all 50 states necessarily. Certain states have certain needs, timing's right in certain states. But the federal government puts up, a 70% or so, depending on the state, match. You've got literally millions of people. This is the number one budget item that governors want to save money on. I don't care if you're a red state or a blue state. If you're working in Medicaid agency, you care about people and their health and solving problems, whether it's everything from foster care to maternal health to healthcare for the medically fragile, to long-term care. You get nothing but problems. You got a list of problems a mile long. So if someone comes into your office and you're HHS administrator or you're a Medicaid director and says, I've been working on how to solve some of these problems or one of these problems, and I have some ideas. You're going to take that meeting and you're going to have that conversation. You got to be operational. This isn't a PowerPoint business. This is actually getting into communities, getting dirty, rolling up your sleeves, working with people in communities, and understanding how they live. And if you can't do that, then it's probably not the right business for you. But if you can, it's not a financial arbitrage business. It's a real healthcare, health services, social services, whole person model. And the companies that I've seen do it well, and we have a number of them who do it well to varying degrees, the rewards are enormous. And the rewards are not just financial. The rewards of building an impactful transformational company are enormous.
Specifically on this kind of concept of whole person health, and in other episodes, we've talked to people like Mandy Cohen, we've talked to the people designing the CalAIM initiative in California. Several of your portfolio companies are in this space, whether it's social service referrals or bringing meals to folks or really focusing on the housing piece. And I'd love to have you share some of those stories of what are those companies working on? What are they experiencing? What are the impacts that they're starting to see and have? Cityblock is another example for you, Unite Us. Could you share a couple of those examples of companies working in this space, and what are they delivering? How are they scaling? What impact are they having?
Sure, I can, and I'll let me just give you a quick selection of a few. We have, 30 companies that we have investments in, and they are all in one form or another figuring out how to take a complex population or a population that's been ignored and meet needs like that. You mentioned Cityblock, so I'll start there. They're now over 100,000 members in 7 states. They take fully capitated risk on the most complex of populations. And that means people who have severe mental illness. That means people who are homeless or are moving between locations. That means people who have enough chronic conditions that they are really slowly dying. And it means people who live in neighborhoods and communities where they have very low trust with the healthcare system and very low access historically. Their model is very simply, they pioneered this notion of hiring people from the community, giving them technology, having them pound the pavement, work the streets, build trust. They have the highest engagement of any company that I've seen in any space because they build these trusted relationships and they solve real problems for people. So if you're unhoused, it's almost impossible in New York, for example, which is one of their markets, to find housing. But there are 2,500 beds in New York, just to give you an example, that are reserved for people with severe mental illness. Problem is, if you're homeless and severely mentally ill, good luck go finding a psychiatrist to fill out an application for you. They have psychiatrists that do nothing but find these folks and fill out these housing applications for them and help get them into housing. And as we know, housing first, there's a lot of evidence that makes an enormous difference. Another investment we have is a company called Plume Health, which serves the transgender population. It's the largest provider of care to transgender Americans and the largest number of transgender providers. Something extraordinary happens when you join Plume. If you need gender affirming care and you're not getting it very well, or can't find a provider that doesn't recognize you, it's an enormously deflating experience. I mean, imagine not feeling not seen or heard or misidentified. People who join Plume within 30 days, this is one of the most remarkable things I'm going to say on this show, see an 80% reduction in depression and anxiety after 30 days at Plume. And that's a reflection of the fact that they're starting from an awful, awful, awful place. And nobody sees them and nobody's helping them and nobody's connecting with them. And so the transformation is almost overnight. And as you know, Claudia, this is the population with the highest suicide rate of any group in the country. So they're doing important work there. Eleanor Health provides whole person care for people with substance abuse disorders. They have a harm reduction, which I know everyone on this who's listening to this knows what that means. Whole person model, which means that they wrap a whole bunch of services around folks. And it's highly, highly evidence-based. They measure everything. They measure every encounter. every bit of progress. And they don't just look at kind of, do you have a positive or negative urine sample? That's not like there are many, many, many more important things like craving reduction and anxiety and depression and things that are part of people's journey when they have an addiction. They understand addiction's a chronic illness, so they treat it the same way they treat you if you had cancer, with compassion, without blame, with all kinds of resources. And, they have 30 odd clinics. And what's remarkable to me is the rate of improvement is extremely consistent in every clinic because they do things in a way that's just better. It's about a 70% reduction of cravings, improvement in job readiness. And then the fourth company I'll talk about, just to give you a scattering, is a company called Spark Pediatrics, which works to care for kids that are born with medically fragile medical conditions on Medicaid. So picture this: you're a parent, you have a child that you've been waiting for your whole life. You're excited, and they're born needing a trach and a wheelchair. They've got physical disabilities, but they're entirely mentally whole. They have the same hopes and dreams. And as a parent, the last thing you want to see is that dream crushed. Well, the reality is what happened in this country today is it's so hard to get through the administrative system and paperwork and get home-based care for your child. And even if you do, keeping someone is almost impossible. The divorce rate is almost 100% within the first several years of having a disabled child. Spark sets up an incredibly interesting, humane program that's a lot like PACES for elderly, where they help the entire family. They provide a set of services in a setting they socialize kids, and they basically sponsor the belief that everything, so much is still possible. Even we all have our limitations, but so much is still possible. And the turnover rate is about zero, unless they graduate kids into other types of programs. So those are 4 of the 30 companies we've invested in. It should give you a flavor for the fact that you got at its heart an entrepreneur or a team of people that see a problem, care about the problem, want to go deep in solving that problem, want to really understand it. And we have to have a certain willingness for people to experiment, for people to try to get it right. And in all of those cases and many others, whether it's maternal health, mental health, medical transitions of care, PACE programs, there are so many people in need of better care. And these models are so widely available that we get extremely excited. And that's why I kind of wonk out on some of these models. And the goal is to make them national, right? The goal is to start them, find them, see what works with some population, and figure out if you can make them the prevailing model in the country.
What are the areas, you've mentioned a few domains that I think are incredibly important and almost like so obvious. Are there other opportunities you're seeing that could become category killers that folks haven't been thinking about enough in the Medicaid space? Like, what are the things that are kind of in your mind as you go to bed at night that you'd like to see more investment in companies around?
Well, the team does a ton of work trying to understand these problems and trying to understand what the solutions are, but whether it's meeting with entrepreneurs or doing research. And I would say, there are a lot of broad categories where you go, yeah, we could do better at 30,000 feet. You mentioned mental health, and we've talked about that. Women's health, we could do a lot better. Early years, the first 3 or 4 years of someone's life, we could do a lot better. Helping people as they get frail and forgotten and lonely, we can do a lot better. People who have developmental disabilities, we could do a lot better. People who are veterans, who are back home after serving, we could do a lot better. People who live on Indian reservations, we could do a lot better. There's no shortage of problems. And the question is, which ones? The foster care system. I mean, I'd be hard pressed for you and I if we spent the rest of this conversation trying to find, well, that really works well. Let's just leave it alone. There's not a lot of that. Rural health, which is another example. We could do a lot better. Now people have to get creative and try different models and try different approaches. But the ones that ring true to me are the ones that come outside in, the ones that begin with, if someone begins a conversation with me or any of us and says, hey, Andy, here's a neat way to make money, you've lost me already, because there are plenty of ways to make money in this world. And sadly, there are plenty of ways to make money in healthcare that don't accomplish a lot. But if you come to me and say, you know what, I really understand the needs of rural Americans or moms on Medicaid, or we really understand this need, or foster kids, and we think there's a better way, and we only have a small amount of data, but here's what we've seen. You're going to pique our interest. And we're going to say, well, what help do you need? And that help may include capital from us. That help may include policy changes. That help may include other kinds of things. But that's kind of what we're there for. That's our platform.
On a slightly different tack, but you made me think about it. I've always wanted to see more efforts, and I think they're challenging to produce, that create a potential financial impact and social impact knit across social services and health, whether that's impact bonds or something else. And as we look at whole person health, you begin to estimate that. But some of the benefits are really going to fall well outside the healthcare. I mean, they're going to fall on the jail budgets of counties. They're going to fall on school, how schools perform. And I've always kind of stepped up to that and then stepped away because it's just so complicated. But I'm curious if you see models of bringing together the impacts and the benefits across these silos as something that has a future.
I think our perspective is there are, and I've advised a number of states and governors on this topic before, but having, number one, a pool of community dollars that you capture from the managed care plans. Oregon is one of the pioneers in this, that says, if we create savings, we're not just going to use it to pay bonuses to providers. We're going to create a pool for the community to be overseen by the community that can invest in programs in public health. And rather than taking the money out of the state and moving it to Minnetonka or Indianapolis or Hartford, Connecticut, or wherever, you've got to leave a certain amount in, and it goes towards health improvement. The other thing I've seen is you talked about impact bonds. I think, New York is considering, and I would advise states to consider, if you participate in the Medicaid program in the state, maybe you should be required to hold in your portfolio a certain amount of bonds that go towards this sort of public health, public good outcomes. So, you're investing in bonds that renew, and these bonds, the money from these bonds are used by the state to cover the things where nobody's going to get a real return, and yet they're not big enough to be solely a government function. And there are a lot of those areas of public health where we're like, gosh, someone needs to make this investment. And the market doesn't always work, and people don't love funding the government. So those things come up. And I would ask more of people that are making money serving low-income people or serving anybody in my state to participate in some of those kinds of things.
I can't leave this conversation without focusing on some just straight up policy issues. And I don't know if you saw it, but there was a Twitter conversation where people had a lot of suggestions for things they wanted to hear your take on. So I'll dig into a couple of those. Obviously, a lot of our gains in insurance coverage could be challenged with the upcoming Medicaid redeterminations. And I think there's a lot of worry that folks are flat-footed, that there's not enough energy going into this. Are there changes you think could be made like within the next 2 to 3 months on the executive branch side that would temper the losses?
I mean, look, let's just start with the problem here. The problem, is, if you put numbers around it, is there are about 15 million people that estimates suggest are going to lose coverage. 8 million of them are people that may no longer qualify for Medicaid. And those are people who, and by the way, I think if everyone doesn't know real quickly, the national emergency really prohibited a lot of actions from being taken against low-income people, including kicking them off Medicaid, kicking them out of their apartments, and so forth. Those go away. And as those go away, people are going to face a new reality. But those 8 million people qualify for very highly subsidized coverage on the exchange, and that can be worked. And then there's another 7 million people, and this is the really interesting part of this problem, who estimates are do still qualify for Medicaid, but will be dropped because they won't comply with the administrative paperwork in time. And there are some states that are going to work really hard to get those people enrolled. And there are some states that are going to work really, really hard not to get those people enrolled because it costs money, and it sort of depends on their philosophy. And I won't pick on any governors, but there's one governor that had come out and pretty much said, we're going to get people out, as many people out as quickly as possible. I don't think there are practical policy levers to change the ending of this redetermination suspension. But I do think there's going to be everything that can be done should be in the realm of extending the time, providing assistance, lowering the administrative burden, and engaging partners. I will say, I'm proud to say that of like what some people are doing. Walmart, for example, which a lot of their customers are going to be redetermined, is setting up a full service to help people get their redetermination done without cost, and they're working with different health plans to do that. So people need to lean into this challenge, and I think it is. But there's no doubt that there's going to be people that are covered today that are going to lose coverage, and we just got to minimize that number. And the exchanges now serve 15 million people. They are highly subsidized. It's not as good a coverage as Medicaid coverage, but it's broader coverage. So perhaps we'll have, by broader, I mean broader network coverage. So perhaps we'll have exchanges that are, working hard on this. I've seen cooperation agreements between Medicaid plans and exchange plans. I don't know what's going to come of it.
And I think, a dark reality underneath all this is that you called it foisting, bureaucracy on poor people. And that is an explicit strategy to lower budgets. And so as long as you are in a state where your budget is tight and there's not political support for Medicaid, the Medicaid enrollment, and for that place in the budget, that will be a strategy that you use. And so it's hard it kind of brings up this whole question about support for Medicaid, and is there a way to just increase that more broadly? And that leads me to my second question. With the discussions about potential cuts to the federal budget, I think many people have maintained that Medicare and Social Security is off limits for cuts. Medicaid has not had that same coverage in the conversation. If we were to try to launch a campaign to include Medicaid in the set, and maybe it's just impossible politically, but what arguments might be successful, whether at a federal or a state level, to extend that kind of no-touch zone to Medicaid? Because so far, I'm very worried about where things are headed.
Yeah, it's interesting because even though Medicaid doesn't resonate as much politically with people as Medicare does, because again, people can see themselves aging, but if they haven't been low income, they may not get it. When you look at the popularity of the Medicaid program, it's incredibly popular. People are really supportive of it. And, attempts by the Republican Congress and Donald Trump to try to cut back Medicaid pretty severely ran into a buzzsaw. People didn't like it. It's also funded very differently. It's funded through matching grants and through states. And so it's a bit of a different animal for people as they think about politically as they age. So I hear you. I do actually try to add Medicaid into the conversation when people say no cuts to Medicare and Medicaid. Medicare and Social Security. It's a practical matter, though. The cutting comes largely from the states and in Medicaid anyway. So I think there's a lot of work that has to happen in different places to make sure that we're supporting Medicaid. The other answer to your question, Claudia, is just reminding people of some facts. 50% of births in this country today are born to moms on Medicaid. These are kids who want to have a good start in life. I don't care who you are, what your politics are. People who live with disabilities, Okay, if you're Democrat or Republican, you've got to understand people with disabilities don't have other choices, and it's the only way them to be funded. Low-income seniors and nursing home care funded by Medicaid. So we tend to think of that as Medicare, but the public does at least. But we all know it's Medicaid. And then working Americans that can't find insurance. So these are 70 million people who we ought to remind people who they are, because I think people's image still sometimes goes to something that they can be dismissive of, because they could say, well, this is some unknown, unnamed person. And there's some racial prejudice and some bias in people's thinking. So it always surprises people when I tell them that, in West Virginia, 60% of Medicaid beneficiaries are white. And around the country, about 40% of Medicare beneficiaries are white. Not that should matter, but for people who kind of have this sort of either subliminal or overt prejudice, they just need to know the facts. Medicaid is there for everybody. It's a commitment from our country. We've made it since 1965. Before that commitment was made, we had a system where there weren't even cracks people were falling through. There just was nothing for people, and we can't do that.
Yeah. I was struck by some recent reports about credit scores and also about medical debt and the impact of Medicaid expansions on bankruptcy and medical debt. And I've been wondering if the kind of economic well-being of families is also a part of the argument that
bankruptcy, medical debt, home ownership, job security, the health of the hospitals, the economy of the region, and then maternal outcomes, child outcomes, cancer outcomes, cardiac outcomes, all of those things, every single one of them demonstrably different and improved in a place like Kentucky and all the places that passed Medicaid expansion. Just compare Kentucky to Tennessee, one off. Kentucky expanded, Tennessee didn't. But it's true in every single study, all of those outcomes, every single one of them that are quality of life and health related, are better in their Medicaid expansion. And it makes sense. If you put a little more money in people's pocket, put a little more security underneath them, they're going to live their lives. They're going to take that risk and take a better job. They're going to, not worry as much. The kids are going to be healthier and more stable. All those things.
There was even a recent study showing rates of child abuse went down when people are insured, which, makes sense because there's less stress and there's more support for that family. So one final kind of policy, well, maybe two final policy questions. One, almost all states now have transitioned their Medicaid programs to managed care with a couple of exemptions. And yet, I think among some folks, there's really lingering questions around the efficacy and impact of those plans. If I were a governor, how would I go about evaluating whether plans are adding value? And if I find they're not, what would I do about that?
Well, this is true of Medicaid plans. It's true of Medicare Advantage plans. It's true of anybody. It's true, quite honestly, of defense contractors. Anybody that we as a government hire to do a job through a public-private partnership, we need to hold to very high standards because we're paying them taxpayer dollars to deliver things the taxpayers expect. And that's really, really an essential commitment. Now, I'll tell you that, for people who want to say, well, should we really be doing this in the first place? The answer to some extent is that while each state can do things their own way and do things differently, the resources at a federal or state government are very low. When I was running CMS, we had $1 trillion budget and 6,000 people. So, all you can really do is partner with people who are, in the line of sight of delivering services and care to people. So increasingly there, I think there's a focus on better RFPs that say, you need solutions to problems we have, whether you're in New Mexico and it's an Indian reservation, whether you're Georgia and it's maternal health, whatever it is, and expect more from the private sector to deliver. Expect innovation. Force people to come to the table with better ideas and review what they do and review their work. And that's kind of where innovation can sometimes be of help.
Yeah. Well, let's transition to the final two questions that I ask every guest. The first is, what is a leadership lesson you learned the hard way?
I think it all comes down to things that I think we know, but sometimes we forget. Accountability, culture, clear communication, clear expectations, talking straight, well-defined roles. And I learned those lessons. I don't know if I learned those. I would say being involved in two major turnarounds, one for the ACA and one for the COVID program, helped me understand that in those kinds of times, those kinds of crises, people are willing to forgive the general normal rules. So you could basically pick up the phone and get stuff done much faster. And the lesson it taught me was that in any time, if something's important, even if it's not a crisis, you're talking about helping serve low-income communities and all those things, the same should apply. And so those disciplines, culture, accountability, clear communication, giving people a sense of belonging and psychological safety so they can be part of the team, those apply in almost every setting imaginable. And now I probably approach everything I do with those kinds of values in mind.
Finally, is there a question you wish I had asked you? And if so, what was it and how would you have answered?
Well, look, I think if I understand your show, it's all about the intersection between what we do in healthcare every day and the other things that happen in people's lives and those parameters and those policies. Because we clearly underinvest in many of these other areas like housing and trauma care and other things, and they then show up in the healthcare system. And other countries do it differently and better. I think if you can't get more money out of government directly, then this is where innovation could play a role. And I think the question that, you want to be asking is, where should the lines be drawn? The lines are clearly moving. We're now clearly allowing non-healthcare investments into healthcare work. So I think, you, not just with me, but with all of your other great guests you have on the show, are going to really be instrumental in helping us wrestle with that question of where does that line get drawn and how do we draw it? What are the creative ways to draw it well?
I want to thank Andy Slavitt for joining me on The Other 80. One big thing I am taking away from this conversation is that the stakes are incredibly high right now. First, delivering whole person health through Medicaid is only possible if people are actually covered by the program. But an estimated 50 million people risk losing coverage with the end of continuous enrollment on April 1st. That's almost 20% of the 85 million people who have Medicaid coverage today. Second, Medicaid is a great space to build meaningful companies. It's a huge market, and it's where the needs and opportunities for impact are greatest. Many of you have reached out with suggestions of guests and topics to cover on The Other 80. Keep those suggestions coming. You've also shared that the time is right for these conversations about moving rapidly and equitably towards whole person health in this country. So let's keep talking, and thank you for listening. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for links to Town Hall Ventures and Medicaid facts and figures. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.